Good afternoon, everyone. Thank you for being with us in the middle of the second very busy day of the conference. Thank you for accepting the invitation to be parts of this panel. Let me only briefly remind you that we'll be talking about the economic dimensions of smoking control and harm reduction. So considering both health-wise and economics approach to this point. Well, the members of this panel, let me briefly introduce all the panelists are Professor Emanuele Bracco, who graduated from the Catholic University of Milan and he continued afterwards at the London School of Economics as well as at the University of Warwick. What is very important for today's discussion, his research covers most of the areas of the public economics, including the public politics and the individual behaviors, individual choices. Professor Bracco, it's good to have you here. And then we have, hi. And then we have a Professor Mravčík, who graduated from medical faculty in Olomouc, and now he's the acting head of the Czech National Monitoring Center for Drugs and Addiction. So very crucial from the point of view of the today's panel. And he's also a member of doctoral board on addictology at the first faculty of medicine in Charles University in Prague. Victor, it's good to have you with us this afternoon. And
Hello.
Hey, let me extend a very warm welcome to Arkadi Sharkov, who's a macroeconomist with his master's degree from Maastricht from the public policy, and who's working on, amongst other, on drug policy and optimization of public spending in the field of healthcare, which is basically what we're aiming to this afternoon. Well, also, Dr. Drucker should be with us. Has not joined the meeting yet. Well, we hope that Tomas Drucker will join us. He's the graduate from the Faculty of Law at Trnava University. He served as the Minister of Health as well as the Minister of Interior of the Slovak Republic. Now he's very busy with the major projects in national health insurance. So also this attitude, this point of view would be very useful in our discussion. Well, we have the panel scheduled as follows. We have planned two introductory remarks. One of Dr. Drucker, who is not with us yet, and the second of myself. So I need to start as a first presentation, and then we have four major subjects or four major bullet points to discuss and to conclude on. So I promise that the presentation will take 10 to 11 minutes only, so that we have enough time for the discussion afterwards. Gentlemen, let me try this. It works. Okay, it does. Well, if we looked at the average longevity, so the expected lifespan at the birth, we see that it's a little bit bound to the income. So the higher the income of the country, basically the longer life expectancy of those who are born in this country. Well, it used to be all the same in the past 2 centuries ago as well. Of course, the life expectancy was much shorter and the income was much lower, but the proportion somehow remains the same. And the proportion is driven by 2 factors. One of them is the infectious diseases. So what the risk factors that are outside aiming at the human health. And the second are the chronic diseases that are bound in 100% well, absolutely almost 100% to our habits. So these are all the risk factors behavioral. Now for the past 1.5 years, we're dealing mostly with the pandemics. So we're saying, okay, well, the pandemics already killed, as we know, almost 5 million people, which is a huge loss. And we say, well, the pandemic is a big threat to our health, big threat to the health systems. When we look also at the measles, Ebola, and Zika virus that took around 200,000 lives in the past 5 years, so we see that it's a real powerful threat. But uh, uh, as I already mentioned, that now we are facing more uh, contemporary or newer risk factors, because the old risk factors, which is the orange line, were undernutrition, indoor air pollution, water and sanitation hygiene, and these were the subjects that were aiming at our health and were really influencing the longevity, well, the quality of life, and so on and so forth, and also pressing the economics of the healthcare system. But now, for the past 20 or even 30 years, the behavioral risk factors are more important than any others, which is binge drinking, tobacco smoking, physical inactivity resulting overweight, and so on and so forth. So we have a huge change in risk factors, and we know, coming back to the subject of today's meeting, that smoking, as you see, is the second biggest risk factor for chronic disease development in the world. When you compare, of course, outside of the time of pandemics, when you compare the risk of smoking and the risk of infections, the risk of smoking is almost ninefold bigger than the risk of infection. So smoking takes 9 times or 10 times more lives than the infections do. Well, let's see on all the non-communicable diseases that take 40 million lives each year, with cardiovascular diseases being the leader, the leader killer, of course, with over 17 million, the cancers, well, 9 million, respiratory diseases, especially of the lower respiratory tract, around 4 million, and several others to follow. We know that we are now trying to fulfill the strategy of sustainable development goals of the United Nations. Well, looking at the goal 3.4, which is to reduce by 1/3 the prenatal mortality due to the non-communicable diseases, we know that we have the 6 factors that we need to focus on. And first of all, again, is reducing the tobacco smoke. There's a best buy list built to show investing in which of the factors, well, in defeating of which of the factors will bring the biggest gain in the future. So at the top of the list, oh, I'm sorry for that. At the top of the list, we have the dietary change. Well, the unsafe diet, putting together sugar, salt, and several others. So you have a 13-fold increase in your investment. If you invest $1 in health, you have a 13-fold repay in not even 20 years. Number 2 on the list is binge drinking. So defeating binge drinking will be the second best investment in public health. And the third one is smoking. Defeating the habit of smoking will bring us an 8-fold return on investment if we invest $1 today. Let me show you something that always stresses me when I think of that or when I look at that. Simply, when I look in my country, in Poland, at the expenditures and the loss of productivity due to the tobacco-induced diseases, I'm looking roughly at a 7 billion Polish zlotys per year. But then, when I look at the excise and VAT income of the budget every single year, I look at over 23 billion zlotys a year, which means that from the point of view of the Ministry of Finances, I earn 23 billion and I spend 7 billion. So I have plus 16 billion zloty a year budget. This would make me a conflict of interest if I have to choose biggest tax income or better health condition of the nation. So I think that this is something that we need to help the politicians with, because this conflict of interest, especially when we look at the cost, the most costly diseases due to death, disabilitation, and the amount of diseases, so the number of people sick, is cancers, all the cancers. This is around $1,000 billion. And absolutely, these diseases, I mean cancers in general, are bound to cigarette smoking. When you see the two curves, one of them, the preceding one, is the one showing how the cigarettes used to be sold, so the amounts of cigarettes sold every single year. And then the red curve that follows by 25 to 30 years. This is the time span. So this is a time span of one generation. So we have a peak in morbidity and mortality from cancer diseases, which is absolutely bound time-wise and is strictly bound in physiology to cigarette tobacco smoking. Well, this 2 decade or over 1 decade delay is needed to observe the effect. So this is one generation gap, which is very typical for any prevention means, for any prevention methods that we are using. But we already know that we have ways to reduce the impact of cancer on the morbidity and mortality of the society, and this way to reduce the impact of this group of diseases over the economics, health economics, and the country budgets. Well, please look at the rightmost part of this graph. We see that the tobacco smoke induces induces cancer. Let's say it's at 100%, the highest possible rate. Then this is 10 zeros. Then we have the new products, including the heat not burn products, that are 100 times less probable to cause cancer process and cancer sickness than the original tobacco. Then we have several other products following, including e-cigarettes. So we know we do have a tool of harm reduction. The problem is that we do not use the tool frequently enough. Where should it be put in? When we have a doctor, we have patients, and the patients come to the doctor. Well, he has his regulations, he has his knowledge to serve the best he can the patient. Well, of course, the absolute prime is the primordial prevention, which means we start education with children, and in, let's say, 40 years, in 2 generations, we should be able to say, well, we defeated the habit of tobacco smoking. But this is going to take 40 years, and it's not 100% sure. Then we have the primary prevention, the primary prevention that we already making. So simply, we banning cigarettes. We put some financial pressure in excise tax, in value-added tax, and so on and so forth. Well, we try to act against the social acceptance, to create the social disacceptance for smoking. But if we lost in these two steps, so primordial and primary prevention, then all we can do and all we should do is the reduction of the harm. We have a Polish protocol, Polish document functioning, showing that the fourth step in supporting a patient to quit is to suggest heat-not-burn or other products that reduces the harm. And well, I'll leave you with this couple of remarks that I'd suggest we'll discuss a little bit later. Thank you for your attention. Well, it was brief enough, I hope. And do we have? No, we do not have Dr. Drucker. Something must have to happen. Anyway, thank you for listening to this one. And now I'd like to proceed to the discussion. So, Victor, can I ask you to start the first subject that I'd like to discuss this afternoon, which is where does prevention turn into addiction treatment? Because we're talking about different steps of prevention. Once we fail, we have a person who gets addicted, and then we need to fight his addiction, and we need to fight the consequences of his bad habit. Well, do we have, because we need to talk about finances, about economics, do we have any measures of effectiveness in prevention, especially in prevention of habits, especially in prevention of smoking habit?
Thank you very much, Andrzej. Thank you for your very good introduction to the subject. You basically mentioned all essentials about the prevention and treatment and continuum of that interventions and measures. Well, you know, I'm a medical doctor. I'm epidemiologist dealing mostly with illicit drugs and recently with licit substances, with the monitoring, description of adverse consequences, policies, and so on. By the way, just this year we are for the first time in Czech Republic.
The session has started already. Please log in.
Andrzej, you are on. Okay.
I'm very sorry. This is Dr. Drucker who just called me. That's what I'm so sorry.
Yeah, you're welcome. Well, so I continue. So this year we have produced the first ever in Czech Republic comprehensive report on tobacco, describing the whole complexity of the phenomenon, from policy, regulation, market, use, consequences, and so on. So I would say I'm deeply in the subject now, and a substantial part of that is also the subject we are dealing here, which is harm reduction and alternative nicotine products and so on. What I would like to say, I already mentioned that my background is drug or illicit drugs epidemiology, illicit drugs related correlates and consequences, drug policy. And in this field, prevention and treatment strategies are, of course, part of that, but also harm reduction has been for a long time an integral part of policies or modern policies in our countries. Traditionally, as you said already, prevention is defined as strategies or interventions aiming at prevention of adverse outcomes or prevention of risk behavior before it happens, or delaying the risk behavior to older age, which is often the target of the programs in illicit drugs. And harm reduction can be defined as prevention or reduction of harmful consequences of risk behavior. So harm reduction is also prevention, although sometimes it is also categorized as treatment or therapy. One example can be opioid substitution treatment, which is basically substitution of harmful substance with substance provided in safer therapeutic context. So in broader sense, harm reduction means any strategy or intervention aiming at reducing of adverse consequence of any behavior. Typical example, often given is safety belts in road traffic. And we know, all we know that public health burden of tobacco is predominantly attributable to tobacco smoking, to the use of combustible tobacco products. Let's say we can simplify that, conventional cigarettes. And as Professor Russell many years ago already formulated, people smoke for nicotine, but they die from the tar. So alternative nicotine products have been widely available just recently in most countries. In some countries, they are banned, unfortunately. So they are not traditional part of tobacco control policies. Traditional way how to decrease smoking, and you mentioned already, Andrzej, that to decrease smoking prevalence and to prevent adverse consequences of tobacco burden, have been either prevention of smoking, or we can say addiction to nicotine, or quitting smoking, or addiction to nicotine, informally or in informal or more formal treatment context. And according to my understanding, alternative nicotine products offer new additional strategy how to prevent public health burden of smoking and nicotine consumption without necessarily treating addiction to nicotine. So it's, coming back to your question on prevention and treatment, this partly gave some my point of view on that. I'm convinced that we should use this opportunity as best and as soon as possible, and to use this potential. And sorry for not being here from the early beginning of today program of the conference. But what I have heard from previous session, it was said there as well. So we should inform primarily tobacco smokers about relative risks of alternative products in adequate way, and to use alternatives to stop or to use alternatives in stop smoking guidelines. And in the same time, we should balance benefits and potential risk associated with alternative products, and maybe I could say to prevent moral panic related to alternative products, to prevent very strict regulation or very strict regulatory measures.
Thank you.
That's it, what I've prepared for the beginning.
Yeah. At this point, we'll come back to this matter in a while, simply trying to find out how to promote and how to use the availability of the new technique to help. Dr. Bracco, Emanuele, please, the same subject, what is prevention, and do we have any measures of effectiveness? Because from the economics point of view, fine, we have some prevention, but we need to ask ourselves, is it worthwhile spending money on the prevention? So does it work or doesn't it work? How to deal with that in this very case of tobacco prevention?
Yeah, so I think that the evidence we have on the say medical help on quitting smoke, like with I don't know, nicotine patches and medically led intervention is very it's sparse and typically says that it doesn't work very much. I mean, all the money spent by government in helping people to quit to smoke, it's not really going in the right direction. So in this sense, maybe the tax instrument and the pricing instrument may be a better conduit for this kind of policy. So to give you an example, the relative price between say normal cigarettes and nicotine transmitting the nicotine device, electronic cigarettes, and all this kind of innovative nicotine products may serve as a conduit through which we affect consumers' behavior, veering towards less harmful usage, less harmful consumption. Even if there is, of course, there is a bit of a resistance in government in promoting through the price mechanism this switching between, say, old-style cigarettes and innovative nicotine delivery products. I think this is due to historical reasons. Maybe the other reason is that as these are innovative products, I think there's a lot of risk aversion in saying these are really less harmful. I mean, the evidence is that they are less harmful. They are less harmful. The long-term evidence, of course, is not there because we haven't had a long time after their introduction. But both the mechanism for which they work and the absence of tar, citing Professor Mravčík, it points towards and also the evidence that you showed. I mean, we know that they have at least one order of magnitude less harm with respect to traditional cigarettes, let's say. So I think that probably the government should be a bit more proactive in trying to seek a harm reduction policy using the taxation and pricing mechanism. And I'm saying this also, I was looking at your figures in which you set against the healthcare expenditure and the excise and VAT revenues for the government. And I think those are I'm sure those are true figures for Poland, but my understanding is that I think in Western Europe the balance is not as unfavorable. I mean, I think that the healthcare cost of smoking, maybe they do not cover the VAT and excise expenditure, but probably they are. If you add to it the loss of income and the indirect costs of getting sick because of smoking, probably they end up being more costly than the revenues governments make out of excise and VAT. And then if we add the disability adjusted life years and we monetize that, we use a money metric to account for that as well. I think that the balance is very much favorable towards policies that aim at reducing smoking and conducing people towards switching or quitting at the same time.
Thank you very much for this comment. Especially, in my opinion, it's very important the difference that are in the proportions of income versus spending, if we can say it this way. In Central European, Eastern European countries, and let's say the Western European countries. So I think from the, again, Minister of Finance's point of view, it's much easier to promote anti-tobacco campaigns if he doesn't lose 1/5 or 1/4 of his entire year budget, because promoting a campaign, suicidal campaign, where he loses 40% or 35% in the case of Poland of the all excise tax income isn't true. Well, Arkadi, I'm turning to Dr. Sharkov, who's an expert in macroeconomics, but he also comes as myself from this part of Europe. So how are the proportions? How is the difficulty of this decision makers in Bulgaria?
So there is as I spoke before, that there is no one measure that fits every country in Europe. If we're speaking of measures of Europe, you know, we're a country in the periphery of Europe. 10 years ago, we had a huge contraband of cigarettes coming from Turkey and other countries around us. And you know, in the economic terms, there is the so-called Laffer curve. So there is a marginal taxation increase after which the revenue starts to drop down. So you can increase the taxes, VAT or excise, to a certain amount. After that, either contraband comes out or the revenue starts to reduce. So taxation should be very carefully used when you want to, how should I say, motivate people to stop using a certain product or to transit to another. Sadly, in Bulgaria, what they did is to almost equalize the excise for non-combustible tobacco products with the combustible ones. And of course, the argument for it from the former president of the financial committee in our National Assembly in the parliament was it's smoking and it's revenue and it's good for the Ministry of Finance. This what was it? No health argument came out from her, and no one from the healthcare committee gave any health argument towards promoting non-combustible tobacco products compared to combustible ones. We did a study here actually in Bulgaria, which we tried to measure the public health and economic effects of the switch in consumption habits. Basically, to quantify it, we used the disability adjusted life years, which is the most easy way to quantify it. So we got health data from the National Health Insurance Fund on 4 diseases, which are the 4 main diseases for which are connected to tobacco usage, which is the diseases of the circulatory system, cerebral infarction, neoplasms, and COPD. And out of that, I'll give you just a general conclusion at the end in terms of in economic terms. Based on the DALIs, the potential loss of profits in the economy due to ill health, disability, and early death, we calculated that in 2019, the smoking-related damages incurred by the economy amounted to 3.3 to 5.7 billion, or 2.8 to 4.8 out of the GDP of the Bulgarian GDP. The potential direct effects, including decrease of lost profits from the change in the consumer behavior and the resulting lower negative effects for the health of the consumers, may reach 2.8 billion in 2019, which already has been reached. And of course, we did a couple of scenarios for transitioning from combustible to non-combustible, which we concluded that may lower the death rate and also the morbidity by 48 to 83%, depending on the scenarios. So nobody, sadly, nobody here is using data, health data and health economic data when they're doing policy analysis. There was in the policy field, there was a stagnation. Now there is movement. But whenever it comes to tobacco, there is either the fanatic ways of everything should be banned, combustible and non-combustible should be banned. And they're not taking into account the prophylactic side and the tobacco harm reduction, which is basically promoting good health through transition or through stopping of smoking. So there is no coherent communication between the institutions and the policymakers in the field of the NGOs, for instance.
Okay, thank you for bringing this up. 2 important things. One of them, the increase in the losses as calculated in GDPs of the in percent of the GDP in Bulgaria, which is, well, a better way of counting than in zlotys or in dollars, because these are not comparable. And the second thing you were saying just by the end of your presentation, that we have the attitude that well, all smoking, all tobacco is bad. So we have the same devil. We do not have enough knowledge, or not enough wisdom is being spread, that everybody who is interested, who's a smoker or a smoker, would exactly know what's the difference between the regular tobacco products and the new innovative tobacco products, which is a very important thing as we come to the solutions. Well, the second round. Well, I see that Dr. Drucker joined us. Thank you for that. I know that you had some important things that kept you. We'll come back to the presentation in a while. But now, Professor Bracco, Emanuele, would you start another round of a discussion on a topic very related to the first one, which is the true cost of the burden of addiction. So, which is the true cost? Which cost we do see? So the treatment of people, the necessary drugs. What we see, what we do not see, and what is really hidden behind the costs of tobacco caused illnesses. So I mean the indirect costs, whatever.
Sure. Yes. So I mean the cost of the smoking, traditional cigarette smoking related diseases, we can decompose it in three major components. So the first component is the easiest to think about, which is the actual healthcare cost of, the medicine, the doctor, the hospital stay, all the really core healthcare costs mostly borne by government through the national healthcare system, at least in Europe, or indirectly through the insurance systems that are still heavily backed by the public purse. And this, I mean, to give you an idea, I mean, we know that about 60% of COPD is attributable to smoking, and in Europe, this cost of the healthcare cost of COPD, whether it's because of smoking or not, is calculated to be about 23 billion per year. Now, on top of this, there's the second element, which is again quite intuitive, which is the fact that if I'm in hospital, I'm not working, I'm not earning money, the economy is damaged by the fact that I'm not productive anymore, I'm less productive. And this is the so-called indirect cost. And this is, again, according to some review of literature at the EU level, if we focus only on COPD, which is the most common respiratory disease related to smoking, and it's also the most common disease related to smoking in terms of number of patients, is about the same. It's about 25 billion per year in this indirect cost, let's say lost productivity and loss of income. Now, the third component, which is the one which Arkadi was mentioning as well, is the fact that as I'm getting sick, I'm bound to lose years of my life, and I'm bound to have a lower quality of life in some of the years of my life. So if you think about lung cancer strikes people, and many do not recover, and their life is much shortened. And so economists come up with this money metric, which is this way of monetizing the life years adjusted for disability or adjusted for quality of life, and trying to give it a number, to give it a figure, just so that we can compare it with other figures and investments. And that's where the main cost of smoking related disease come from, because again, if we just look at COPD, this cost is almost 100 billion per year in the EU or 27 countries. So we can see that.
Well, thank you. At this point, sorry to forget that the time is running, and we have
you're right.
2 or 3 subjects to discuss. And Dr. Drucker, may I ask you, because you used to serve as a Minister of Health of Slovakia as well as a Ministry of Interior, what do you think? What is your experience and knowledge on the total cost of cigarette smoking to the healthcare system?
Thank you very much. I try to summarize perhaps a wider picture on the healthcare expenditures and dependency results on healthcare expenditure, even we are talking specifically today about the smoking. So just very roughly, I think the major issue in healthcare system is really whether we are able to measure and observing and monitor the results. According to European Commission, in 2018, we distinguish avoidable diseases between treatable and preventable diseases, where we also smoking can somehow include. And what we see, and I don't want really go in deep or long conversation, what we can see based on results that there is a clear association between how much money we spend in healthcare and the results we are able to achieve. Just to provide you very small picture, the all European Union states spend per capita, and we calculate it is as through the parity power, and we see that they spend closely twice more per capita than old European or new, I'm sorry, the new European states like the former East Bloc. And we also can see opposite, that the old European Union states have closely 3 times better results in avoidable diseases than the new European states. So coming to the smoking, what you already were talking about is that according to the European Commission, we can see that closely 1 trillion of euro is government expenditure generally on the health. And when we calculate the total cost, what treatment, loss of economic activity, and so on, the smoking cost us, it's roughly 735 billion of euros, what is 74% of all government expenditure on health. And we just use 77.3% of this, I would say, budget based on revenues from excise duty. So if we are able to reduce smoking just for 1% of all population who is smoking, we would be able to reduce the cost roughly for 40 billion of euros. And what was always my goal in Slovakia is to change the system, that we should really focus on results, on expectation, defining the goals, what we want to achieve. So once we know that we want to compare with the better states, with better systems, they are able to achieve a better results in preventable diseases and treatable diseases. So need to motivate a whole system to pay for results. And of course, the smoking is an absolute leading cause of multiple diseases like cancer or chronic obstructive pulmonary disease and so on. So definitely smoking is one part which should be a goal, how to decrease through the preventable.
Thank you for bringing this up, Dr. Drucker. Thank you very much. And I go to Professor Mravčík. Victor, as we heard, reducing by 1% smoking could reduce the spending budget by 40 billion. Well, when you compare these numbers to the amount that's being spent on the prevention and the defeating addiction, what do you say? How much is being spent on addiction fighting and on the prevention of smoking as compared to the 40 billion that could be saved by reducing the smokers by 1%?
First, I have to switch on my microphone. Well, 40 billion and so on, it's so cosmic, figures that it's for me difficult to even imagine.
How much in Czechia you spend yearly?
But the question is how to decrease the smoking by 1%. Yeah? What measures should we use, and what measures are effective, also in light of the products we have available now? Coming back to your question, just now, describing the situation on tobacco, we can't simply identify a budget for tobacco prevention or tobacco smoking prevention or tobacco quitting. There is hardly to find the allocation of the money for that purposes. Yeah. So if you ask me how much we spend in Czech Republic for prevention, for smoking prevention and smoking, addiction treatment, it's very low money, I would say, comparing with this astronomical money, which in the costs of the illness of tobacco smoking or comparing with revenues. Yeah?
I see. Staying in line with what you're saying, Arkadi, would you tell us, how do you think, how should we play with excise tax to promote in this prevention, secondary or tertiary prevention, to promote the new technologies of harm reduction? So, because this will be spending money or, well, losing the budget income, because we need to have some tax support to introduce the new technologies. And as Victor said, well, we do not spend much. We don't know how much we spend, but we do not spend much on prevention. So what would you suggest? Which way to go to be very much cost effective?
So there are two types of ways of stimulating companies for innovation. One is directly subsidizing them, which is actually one of the ideas of the European Health Emergency and Preparedness Response Authority, part of the European Health Authority, which is the worst, the not so feasible method. The other way is through taxation. If we reduce taxation or excise taxation or VAT taxation or some other taxation stimuli to the companies that innovate, and with their innovation they achieve better health and economic outcomes, then this is the right way to continue to innovate in the future of the field of the tobacco harm reduction. This is the best way, because through taxation, innovation can be improved and increased. Through subsidies, it's a bit different, because when it comes to vaccines and when it comes to other drugs, the producer needs profits. If you can profit from your product and you're good in profiting and in promoting health through it, then it's the best way to be done through this. And reducing the taxation will also reduce the end tax and the end price for the consumer, which may transit from combustible to, for instance, to non-combustible tobacco products. So this is lowering the price and improving the healthcare outcomes through it.
Thank you. Yes, Victor, you wanted to add something?
Yes. Arkadi, I mean, was speaking at the beginning about innovation, which is important for the, I would say, appeal of the product for consumers. But I would like to highlight what he said at the end, that I mean, governments should play more with the excise taxes and with the final price of the product. Of course, the appealing is also important, or appeal is also an important factor, but the price is equally important, if not more important. So I mean, the key here is how to titrate the final prices of the product to make the I mean, less harmful alternatives more appealing for consumers.
Yeah, this is a very important point. And slowly summarizing, I come to Emanuele. Well, since you're also an expert in individual behaviors in politics and social choices, how do you find, especially in Italy, what's the acceptance of spending money on innovations like harm reduction? Is it being accepted generally by the public, or it's not?
Hard question. I feel that in this particular moment in time, it would be difficult for the government to argue towards subsidizing profit-making companies that promote the consumption of something like innovative.
Not subsidizing companies, just subsidizing product. Decrease taxes on this.
Yeah, that's what I was going actually. That I think that the most reasonable argument that I think could have some leverage at any level, both in the public and in the government, is to come up with a system of excise taxation on these products that actually matches their actual risk and matches their the harm that they make, in order to avoid distorting the choices of consumers towards traditional products, which are more harmful, just because we want to tax all things that have to do with nicotine at the same level, even if it's economically and health-wise unreasonable. So I think that kind of argument of having a differential taxation that is based on the evidence of harm it's great. It would be able to have some traction.
Okay, thank you. Well, one more question to all of you, staying in line, I think, in this one. Well, to know if the new techniques are effective and how much they're effective, we need to have some research, some observation. Is there any research in your countries? And if yes, who's financing and who's leading the research tending to look at the new harm reduction techniques and to evaluate them? Let's start with Arkadi this time.
So publicly and officially, I cannot say that I know that someone is funding such a research in Bulgaria, sadly. Rarely someone is focused on researching about switching or tobacco harm reduction alternatives. Typically what the analysis are done either by the government bodies, institutions, or they are done from some NGOs, which are basically non-smoking NGOs that focus more on the health effects of smoking, and they're against all types of smoking. So
generally, NGOs are the leaders in well, preparing and financing the research.
Exactly. There is no university that get financed or none of that I know to do a real scientific research on the topic of innovations and better health outcomes.
What's the situation in Italy?
So I am aware of some medical research with Italian data on the medical effect of say innovative nicotine-based products. I'm not aware instead of more of richer research that has to think about the public policy aspect of differential taxation and the effect on the public finances. So in this, all the things that I've read in this realm are with British or American or Canadian data or little else really.
Okay, thank you. Victor, any chance for any data from Czechia about the effectiveness of harm reduction? Any research in this field?
In Czech Republic, we have the same situation as in Bulgaria or Italy. We have reviewed just recently the available evidence, also in Czech Republic, and I can say there is no substantial or robust research focusing on effectiveness of these harm reduction products. Everything is from abroad, as Emanuele already mentioned. And what we have is anecdotal reports, I would say, about uptake of the alternatives in quitting, context and this, I would say, clinical experience with that, but this is everything.
Thank you. Well, we have 2 minutes left. Let me summarize briefly and ask you for one word comment on that. We know that harm reduction is the only new tool that we had in the past 30 years in fighting the habit of tobacco smoking. So this is the only innovative tool, innovative thing that we have. We know that this has to be introduced, so we need research on the effectiveness of the harm reduction. We need the research of the financial effectiveness, because we know that chronic diseases, especially those tobacco-induced chronic diseases, are very costly to the system. So we need to spend as a system, as a society, a lot of money to treat them. But we need to compare the money that should be spent on introduction of the new techniques with the savings we'll have as a system. Of course, the one saving goes without any explanation, without any counting. We save lives. This is the first thing, and this is the medical and ethical attitude. But economically, and this is the third point of the summarizing, economically, we know that promoting the new devices just by tax reduction, but by taxation politics in general, can save not only lives, but also money, and not in one generation time, but in 2 or 5 year perspective. Please, very brief, your summaries of this session, 30 seconds each. Emanuele, you're the first.
Yeah, I would just say to try to inform tax policies on actual risk of each product, and use the tax tools to generate behavior which go towards a reduction of the use of healthcare system and loss of income.
Thank you. Victor.
Yes, years of life lost means lost money. As we said, it's majority, I mean, loss of productivity and lost lives is majority of costs. So I would say incentives for consumers are important. Price incentives or economic incentives are important. We discussed about this titration of the prices and so on. And correct, I would say, information about relative risks of new products.
Thank you. Arkadi, very shortly.
Promoting innovation through lower taxation first, and optimizing healthcare budgets and increasing profits through tobacco harm reduction programs.
Thank you very much. So, gentlemen, thank you for accepting the invitation to speak today in this panel. Thank you, the organizers, for having organized this panel. And I hope this is a good step, that we took the right direction, and we'll go a couple of steps together in the nearest time. Thank you for being with us this afternoon, and have a wonderful day. Bye-bye.